So for our final presentation, we're going to be discussing youth Native American diabetes prevention. I'm Jasmine Sweeney, and in my group, I have Kelly, Amar, Evie, Gina, and David.
For our program, our topic is diabetes. Our target population is American Indians, Native Americans, reservation-based. Our setting is after-school program. We're gonna select participants from All Tribes Charter School, which is grades 6 to 12, and Barona Indian Charter School, which is located in San Diego, both of them. And our prevention type is primary prevention.
For our measurable objectives, we have 3 objectives. They're based on knowledge, attitude, and behavior. For knowledge, we expect our experimental group, 13-year-old American Indians, Native Americans, to increase their knowledge about risk factors of diabetes by 35% by post-test as measured by in-class questionnaires. These will be questions 1 through questions 15. For attitude, upon completion of the program, 25% of the experimental group will report a positive increase in their knowledge, such as physical activity, as measured in post-test through self-administered questionnaire. These will be questions 16 through 29. For behavior, in our program, we expect our experimental group, 13-year-old American Indians, Native Americans, to improve their nutritional diet by 7% as recorded through a pre-test and post-test through a self-administered in-class questionnaire. These will be questions 30 through 44.
Next is our population. For our demographics, we would want to focus on American Indians or Native Americans. They will be located in the San Diego County area in California, which is reservation-based. We would like to focus on our population on 13-year-olds in the 8th grade and all genders. We will preferably want the language to be English. The income would not be specified, and we will focus on the low SES population. For the clinical eligibility criteria, we would require those who have increased blood pressure, preferably in prehypertension, which is ranging from 120 to 139. And for BMI, males without diabetes would be 22.2, and females without diabetes would be 22.6. And other eligibility criteria would be that students would qualify for free or reduced lunch and access for those who are insured and not disabled.
For our sampling method, we decided to use cluster sampling, which is the best choice for our proposal. Since there is a potential for the target population to congregate and allows participants to have an easier access to participate in the program. And using our clusters, which are reservation-based middle schoolers, 13-year-old 8th graders in San Diego County, and all genders of American Indian / Native American ethnicity with low socioeconomic status. And the schools in comparison are Barona Indian Charter School and All Tribes Charter School. And the recruitment method we will use is to contact school officials to gather a list of 8th graders of All Tribe Charter School and Barona Indian Charter School. Participants will have to meet the following eligibility criteria, which is a BMI of 22.6 or higher, blood pressure of 120 through 139, or being qualified for having free or / reduced lunch program to be eligible to participate in our after-school program.
On this slide, I will be talking about sample size. So the type 1 error, also known as false positive, it's concluding that the Youth Native American Diabetes Prevention Program is effective when in reality the Youth Native American Prevention Program would fail. Type 2 is false negative, which concludes that the Youth Native American Diabetes Prevention Program is effective when in reality the Youth Native American Prevention Program would be effective. Our sample size consists of American Indians, 8th grade students of All Tribes Charter School and Barona Indian Charter School located in San Diego, California. Thus, our sample size is small and will require a large effect size. The objective 1 is 60% increase in knowledge about diabetes. The effect size is 0.6. Objective 2 is 45% change in attitudes about diabetes. The effect size is 0.45. Objective 3 is 5% decrease in BMI, and the effect size is 0.05. Objective 1 is the effect size is 0.60, and the type 1 error is 0.05. Objective 2 is the effect size is 0.45, and the type 1 error is 0.05. Objective 3, the effect size is 0.05, and the type 1 error is 0.05. The sample size per group at the post-test is 219, and we have to consider the experimental and control group. So we have to double 219, which will become 438. And the sample size to be recruited is N equals 525.6.
Our experimental methodology, we used a non-equivalent comparison group. Reason being is because the group was not random. We specifically selected our population from 2 schools in San Diego County. Our experimental group is from Verona Indian Charter School, and our comparison group is All Tribes American Indian Charter School. All tribes consist of 53% female and 47% male students, 82% which are economically disadvantaged students. And at Verona Indian Charter School, it consists of 51% females and 49% male students. 29.5% of students are eligible to participate in the federal free and reduced price meal. We made these 2 groups as equivalent as possible because they both are charter schools. They have very close male to female ratio, and they are both economically disadvantaged, meaning low SES. In order to control and address the threats to internal validity, we had history, maturation, testing, and instrumentation. And a way to mitigate history is our program creates a timeline to help identify any possible obstacles that may influence the results of the program. For maturation, our program would need to keep the duration of the program short. For testing, we would need to eliminate the idea of a pre-test / post-test and apply completely different but equal forms of the test. And for instrumentation, we would need to ensure that all information is distributed to the target population uses pre-diabetes instead of borderline diabetes. We would need to make sure that our program does not use the word interchangeably. So throughout the duration of the program, we need to keep the same terms so our study group does not get confused.
The way that we will be collecting data will be through self-administered questionnaires. We chose this method because the participants are at an appropriate age to observe their own behavior and complete the questionnaires truthfully. This approach also allows for confidentiality so that participants can answer questions truthfully without shame or embarrassment. Costs are minimal for this type of data collection method. The demographics that will be covered in these tests are gender at a nominal level, age at an interval level, race and ethnicity at a nominal level, GPA at an ordinal level, and family medical history at a nominal level. Our first objective assesses knowledge and measures the concept of increased knowledge about risk factors of diabetes. All questions for this section are measured at an ordinal level and are multiple choice. They can be seen below. Our second objective assesses change of attitude and measures the concept attitude on physical activity. All questions are multiple choice and are measured at an ordinal level. They can be seen as questions number 1 through 13. Our third objective assesses change in behavior and measures the concept of increased nutritional diet. All questions are multiple choice and are measured at an ordinal level. These can be seen as questions number 1 through 14.
Formative evaluation methods, also known as pilot testing. The methods used to pilot test our program are educational, social support, skill building, and screenings. For recruitment, it is population specific, which in our case is reservation-based American Indians and Alaskan Natives. The setting is specific to San Diego County, conducted at Verona Indian Charter School and All Tribes Charter School. Once participants are enrolled, we will provide a healthy snack throughout the duration of our program, just to reiterate the importance that nutritious foods hold. Experts in our field, we will be using health organization administrations, professional personnel, and general public. A nonprofit organization is Families in Good Health, and they are located in Long Beach. Professional personnel, we're going to be using Lolita MD. She is an endocrinologist and associate professor of medicine, and she works at UC San Diego Health, La Jolla. For our general public, we're going to reach out to the Barona Band of Mission Indians General Council, which is a council of 240 voting members. We will elicit information by reaching out to these organizations/individuals with emails and letters. In this form of communication, we will describe the significance in providing this population with the resources needed to prevent diabetes. We will ask for their insight and advice on our program. We would like to obtain their knowledge on diabetes and are open to suggestions for our program. Community input, we will conduct a small focus group with 10 individuals from our target population and provide an incentive after completing our test run. Refreshments and healthy snacks will be provided for this 2-hour focus group, and we will end it with an interview to assess our effectability with our program implementation. In this interview, we would like to be interested in knowing if they would join a program like ours, and if not, why. What would incentivize them to participate, and what can we do to further educate individuals, and what would be helpful in bringing awareness to the prevalence of diabetes among this underserved population, which is American Indians and Alaskan Natives.
If each component of the program is being implemented as outlined, we will.
For this slide, we're going to be talking about the process, evaluation, and monitoring of the program. So if the program is reaching the target population, our recruitment methods is going to include recruiting the participants. Our program will contact the school officials to provide a roster of 8th grade students of all tribes charter school and Barona Indian Charter School. Our program will then screen the participants by BMI and blood pressure. Students with a BMI. For this slide, we're going to be talking about the process, evaluation, and monitoring of the program. So if the program is reaching the target population, our recruitment methods is going to include recruiting the participants. Our program will contact the school officials to provide a roster of 8th grade students of all tribes charter school and Barona Indian Charter School. Our program will then screen the participants by BMI and blood pressure. Students with a BMI of 22.6 or greater and have blood pressure of 120 to 139 or qualify for free or reduced lunch are eligible to participate in the program. Our program will host a day and time to screen all 8th grade students and record the data and the procedure of the recruitment. If the initial recruitment approach is not effective, our program will expand the population to include 7th graders as well. And our retention method is going to include our participants will be attending the program on the regular basis. The program is an after-school program that involve the participants and their parents are also welcome to join. The participants is going to attend the program on Monday, Wednesday, and Friday after school weekly, and the attendance will be documented every meeting. There will be an outline every meeting, which will include the activities and lesson plan that was performed during the meeting. To monitor the documentation, the person documented will be undergo training to ensure that they're documenting accurately and know what to look for when they are observing and completing the document. For my slide,
If each component of the program is being implemented as outlined, we will monitor those who implement the program. This will be completed through proper training and observation. Doing this will ensure that the implementers of the program are following standard treatment practices by not providing extra incentives, resources, or additional help to any participants. The methods that we will use to monitor participant satisfaction and progress will be through periodically given satisfaction surveys. These surveys will measure if participants are satisfied with the program, if they feel that their health is improving, and if they feel that they are being treated fairly.
For my slide, I'll be doing the timeline. As for our program, it is a school year long. So in the month of August, which is our pre-plan month, the needs assessment and the program development will be happening in that month. In September, our program will begin. So our pilot testing, sampling, and pre-testing will occur in that month. As for the month of October to June, our program implementation process evaluation and data analysis will happen throughout. And for our last month of the school year, June, our post-test and report writing will happen